It's probably more like 40 to 50. And the old literature would kind of say, oh, 20 to 30, 1 out of 3, 1 out of 4. And sometimes it's just not quite that clean. I find people, I'll give you an example of a wonderful woman from Lubbock, Texas, that I was doing my caregiver training speech to her, and I said, Ms. Jones, you can do this for 1 or 2 or 3 years, but you cannot work 3 shifts a day, 7 days a week, taking care of him at the equivalent of the world's most expensive nursing home in the back bedroom, because she was having to pay some help. I said, you cannot do it for 10. And she looked at me and she said, well, with all due respect, Susan, I knew you growing up, and I've been doing it for 11. So, sometimes people can do heroic things, but if you ever looked at any of the stress scales, like the Holmes rate of change scale, where death is 100 points, loss of, well, I guess your own death is pretty much it, but the death of a spouse is 100 points, divorce is so many points, even happy occasions like the birth of a grandchild or Christmas celebration. I actually think Christmas, if it's at your house, ought to be worth about 78 points. But these things, if you have a significant number of stressors in your life over a 2-year period, the chance of you developing a serious, not sniffles, a serious chronic illness, mental or physical illness, in the following 2 years is more than 60%. So these things that seem just irritating and build up over time really are a threat to your physical health as the caregiver. Sleep deprivation is not the new normal. We are living in a society that pretends that's good. I work with way too many young men on the fast track. You just hope you're not driving to them next to them in the lane, particularly when I'm out here in California. I noticed that. But there are people who brag, well, I only need 4 or 5 hours of sleep a night. That's not true. Do your homework. We all need more than 4 or 5 hours of sleep at night. But that's going to be something we brag about, like being busy and everything. So if you are a family caregiver, to plot a little something different for your normal than that would be good. Another thing I see, and part of my consulting work that's been fun, is going into people's houses. I'm part of a team with an occupational therapist, kind of like what the fall people do that have the display there back in the room. I was fascinated with y'all's brochure. I'll try not to steal it without giving you the copyright. But anyway, it's where you're trying to find out why people are falling and stuff and why people are injured. I've been astounded at how many injuries there are to caregivers trying to do physical things with their partners with Parkinson's disease. Just because you can do it doesn't mean you should do it. And anybody who's ever ruptured a disc in their back knows exactly what I'm talking about. There's not enough body mechanics classes out there to train you, if you weigh 110 pounds, to lift and maneuver your 175-pound husband. It's a matter of judgment and of learning new tricks or getting better help. She mentioned here, I got tickled at Dr. Hassett this morning talking about attention span and people drifting off during her talk. All of us in the speaking business, of course, worry about those things. At least this year, Ron and them assigned me a slot before lunch, and I'm so grateful to have been upgraded. The last 2 times I've been in San Diego, I'm always the after-lunch speaker. Well, that usually means one of 2 things. Either they are hoping and praying you can do something that will keep an audience alert and awake, or you've done something really politically stupid in the organization and you should clean it up. So I think I apologize sufficiently for whatever I'd done. I didn't know. And so now at least I'm leading you into a wonderful lunch in a few minutes. I want to talk a little bit and expand on what Melissa talked about this morning with mood disorders, because they are not only common in people with Parkinson's, they are extremely common in family caregivers. The only 2 I'm going to focus on has to do, I'm going to talk about anxiety first, if you'll just look to the bottom of that slide. Free-floating anxiety is that funny, anxious, weird little gnawing quality. It's extremely common among seniors. I have a great deal of stress right now in my own family. My 91-year-old father with Parkinson's and almost everything else keeps trying to die, but he's just not good at it. My 37-year-old son doesn't want to die at all, but has been diagnosed with a disease that probably won't allow him to live too many more years or months even. So I've been kind of, psychotic myself here lately, and trying to think about that. I wanted that anxiety. I said to a friend of mine, I said, I don't know from when I went exactly from being a fairly normal, calm, let's just go with it and see what happens kind of person, to a person that gets up every day kind of waiting for the other shoe to drop. You know what I mean? Where you have these superstitious thoughts like, oh God, disaster's coming 3. Wonder what number 3 is, you know, and things that are not part of my normal personality. I can't tell you how she told me to treat that, but we'll talk about some remedies in a little bit. That anxiety is more common in people with Parkinson's disease probably than it is in the rest of us. It manifests as brooding, excessive worrying. Often it's worrying before it's time to worry. You know, it's the people worried about Christmas when they're still recovering from the 4th of July family reunion. You know, and as I said, I'm like that about the Christmas deal. But it's just worrying without a base, you know, for it. Fidgeting, SLB, that does not have to do with your character or your mother's history. It means it's a medical acronym for shortness of breath. I can always tell who's awake because it's like this guy over here. He gets that right away and everybody else is going, huh? Sleep disturbances, agitation. Now, some of those things are just part of the physical nature of Parkinson's, so it's a little hard to tease out sometimes. But in those of us who are caregivers, oftentimes it comes on over a matter of weeks and months. Generally, we ask for these kind of symptoms to be present at least 4 to 6 months before we treat that with some kind of pharmacologic agent, because the anti-anxiety medications, they're all kind of distant cousins or more advanced cousins of Valium, and they have some sedating qualities, and there are issues just casually using those medicines, even though they can be very beneficial sometimes. Now, jump back up and look at depression with me. It occurs over 50% of people with Parkinson's disease sometime over the course of their illness. We treat that sooner when we can pick up a depression, and a lot of times you caregivers are the ones that clue us to that. You know, you'll ask a patient, well, Mr. Smith, you say, you know, people think depression is like sitting in the corner moping or not sleeping or easy to cry. Well, those may be features, but in older adults, and I use that term loosely, I'm talking over 50 here. So that's like most of you in the room. So I can tell 2 people just got so incensed over here when I said that. Okay, I didn't say everybody in the room, but anyway, the depression is if people who have maybe just a personality change or no energy, a change in their sleep pattern, extremely low mood tone. They quit wanting to do things they used to like to do just fine. Sometimes even very simple things like going out to dinner is just not worth it. You know, and those are clues to depression. Oftentimes you will ask the patient, Mr. Jones, do you think these symptoms you're having might be depression instead of just something about your Parkinson's or your life stress? He says, oh, Doc, I'm not depressed. And the wife's over in the corner going, you know, indicating that maybe there's a second opinion needed there. So you kind of have to think about those things. And sometimes we don't know what depression was until we have a chance to treat it. If depression, she was talking this morning, remember about neurotransmitters? Dopamine doesn't work in a vacuum. It works with acetylcholine. It works with serotonin in the brain. And so it may, if you've got a chemical problem, you may need a chemical balance with that rather than just polish and paint on your toenails or turning over a new leaf or taking an extra Parkinson pill when you hit the golf course. You know, it may require rebalancing of the entire system. And it doesn't just happen in patients. Depression is extremely common in caregivers. I work with a shrink in Dallas. I thought one day he was going to say, I know depression when I see it. And what he actually said is, you know, I think I know depression when I have it. You know, and so it's extremely common. And again, the thing about the treatment, there are some very good medications out there to treat Parkinson's disease. And if you need it at all, it will probably, you may not know you have depression until 3 to 6 weeks into the treatment course with the commonly better used agents. Now, people will say, oh, he is a little better. Or the patient will say, wow, I do have more energy. That may be the only way they notice, but that's a big improvement, you know. So, and if you needed it at all, you probably need to continue taking one of those medications for about a year, and then you can rethink it or have a trial off of it. Some people do need to take it longer. Martyrdom in caregiving is really overrated. And I don't know how we slide into it. I'm going to talk mostly to women here because that's the body parts I understand the best. I never set myself up to be a martyr. I used to teach courses on assertiveness training. I don't know when this all went in the toilet for me personally. It drifted in. It didn't jump in. But here's the deal. My dad really does not like for somebody else to take care of him but me. I'm the designated nurse.